Good afternoon, everyone. I'm Pallavi, and today I'm going to speak on the role of two tissue expanding techniques in hernia repair. One is botulinum toxin type A, BTA, or more commonly known as Botox, its trade name, and the other is progressive preoperative pneumoperitoneum. I thank you for the invitation, this podium, and your attention. I have nothing to disclose, although I wish I had some stocks in Allergan. In this talk, I'm going to cover the objective of the use of this technique in hernia surgeries, the principles of individual techniques. I will cover the technique and some variations in the technique, outcomes, and I will mention but not go into details of some alternatives. I will not go into the hernia repair after these techniques, as this is already covered by most of the speakers. The objective of both of these techniques is to achieve a tension-free fascial closure. Very frequently, all of us do come across some hernias that cannot be closed either with or without component separation. And when fascial closure cannot be achieved, this is a meta-analysis from Neil Smart's group. This is on laparoscopic hernia repair, but we can see that when the defect is not closed, recurrence increases significantly. And this is relatively smaller hernias. It's a laparoscopic repair. So what happens when we go to bigger hernias like this? We all know that bridging repairs are associated with very, very high recurrence rates. So we use different techniques for facial closure. Component separation is the go-to for most of us. However, it does involve extensive dissection, very good techniques, but doesn't come without any costs. Approximately 20 to 50% wound complication, which translates into about 5 to 20% recurrence. So it makes sense for us to keep looking for techniques that can give us lower recurrence with lesser morbidity. Tissue expansion seems to be one of those avenues. I'll start with this really good molecule, which apparently cures more than 800 problems. So in 2017, apparently Allergan sold more than $3.5 billion worth of Botox. That's huge. Going into the mechanism of action of Botox, it's a very busy slide. I'll summarize that. It works on the presynaptic cholinergic nerve endings to inhibit the release of acetylcholine and substance P, other pain modulators from the presynaptic ending, resulting in flaccid paralysis and neuromodulation. Starting with the technique, much has not changed since it was first described by our Mexican colleagues because it works, except initially they did start to use about 500 units, which has now come to about 200 to 300 units by most centers. There are 6 injection sites, 3 sites in each lateral muscle bilaterally. Multiple authors have described different sites of injection. What is to be kept in mind is as we go down, the transversus abdominis muscle becomes aponeurotic anteriorly. So lower down, we have to go a little posteriorly if we want to inject the TMSL. For our center, we use the technique described by Zielinski and others. That's 300 units diluted to 150 ml of normal saline, which translates into 8.3 ml or 16.6 units of BTA at each layer at each site with a 22-gauge spinal needle under conscious sedation. It may be a little bit tricky in hernias like this, lateral hernias, and you can see that in the CT scan, a lot of the lateral muscle is buckled. Remember, BTA causes denervation paralysis. So if the muscle already has lost its innervation, it may not be much use injecting BTA here. For this purpose, a lot of people have started using EMG-guided injections. This is not something that's available to us in our center, but if it is available to you, I think it seems like a really good idea. So this is how we start. BTA is available in powdered lyophilized form, which has to be reconstituted on the spot. Every 50 ml syringe has 100 units of BTA, along with a flush to flush out whatever is left in the tubing, attached to a 22-gauge spinal needle. And we start the procedure with marking the sites first. This is how we do it at our center. Anterior axillary line at costal margin, anterior superior iliac spine, and mid-clavicular line equidistant from, mid-axillary line equidistant from both of these points. We start the procedure under USG guidance, and this is a small video to show how we are injecting in different layers. And the idea is to go from the posterior layer to the anterior layer, so we don't lose planes coming from anterior to posterior. In this one, we have injected the solution in the internal oblique muscle. TA is already infiltrated at another site. And then we go above, and now you can see the solution coming in at external oblique in a second. Yeah, right there. So yeah, this spreads very beautifully between the muscle layers. And this is how it looks pre and post infiltration. You can see 3 clear layers of fluid in between the muscle layers. Outcomes, again, we at our center, we don't have pre and post Botox CT scan available to us because of cost constraints and radiation exposure. But people have worked on it. And this is how it looks. This is a CT scan at rest. You can see that from about 11.5, it has increased to 13.5 at rest. It's okay, not very impressive, but if we ask the patient to crunch, now it's increased to about 18 centimeters on the right side and 17 on the left. What's even more impressive is the 12.5 centimeter defect has gone to approximately 5 centimeters, which can probably now be closed with just a ribstoma without requiring any component separation. Ideal time to repair hernia, a lot of centers are doing it at 1 to 2 weeks, although maximal effect is seen at about 2 weeks. So it may make sense to do it after 2 weeks of BTA injection. Another thing, we were talking about pain modulation. Zendezas and others have reported that these patients have continued pain relief for up to 3 months after BTA injection. So this is a very good side effect of this procedure. Coming to progressive preoperative pneumoperitoneum, I have to confess we don't have a lot of experience at our center with this procedure, so a lot of what I'm going to talk about is taken from the literature. This technique has been old. It's available for us since 1940. It was described and first published in 1947. Again, same principle, expansion and lengthening of abdominal wall musculature with some good side effect. It's a good physiological preparation, a good chest physiotherapy to patient who is supposed to have a loss of domain and suspected abdominal compartment syndrome after surgery. And occasionally it has also led to some pneumatic adhesiolisis, making the intraoperative work easier. There are different methods described, most common of which is a Veress needle insufflation in the OR under general anesthesia and placement of a CAPD catheter. Some people have also used an OPD-based CT-guided insufflation, where they use a small needle to create a small pocket of air in which they Seldinger another catheter, and the procedure can be completed in the OPD itself. So stage 1 is the preparation and insufflation of about half to 1 liter of either room air or medical grade CO2. Stage 2 is a patient either stays admitted or goes home, comes back every day to the clinic, whatever is available to the patient, and every day about half to 1 liter again, depending on the patient's comfort, and when the patient starts experiencing pain, we stop the instillation. On an average, about 8 liters have been insufflated by most authors, ranging from 4 to 13 liters over a period of 1 to 2 weeks. Most authors now agree that there is no advantage of continuing this insufflation beyond 7 to 10 days. There may be some role of thromboprophylaxis in here because we are increasing intra-abdominal pressure. And this is a really nice picture from Bueno Ledo's paper. We are fortunate to have him write a chapter for us on the same technique. Keep in mind that this is an image after both BTA and preoperative pneumoperitoneum, so the entire outcome cannot be attributed to PPP. But this is how it looks pre and post. An extensive loss of domain like this, and the entire content is now inside the abdominal cavity. And this patient is tolerating this much of pressure inside her abdomen, so she probably might be okay after surgery without developing any ACS. There is a concept of accommodating volume, which is post-PPP abdominal cavity volume minus pre-PPP total visceral volume. That includes inside and outside the abdomen. And if this change, I'll just finish in half a minute. And if this change is more than hernia volume, we are supposed to be able to repair this without any problems. Stage 3 is hernia repair after both of these procedures, which I'm not going to cover. Outcomes after just PPP are not very well reported. Most of people have used it in conjunction with PTA, but it seems to work. Some alternatives, plastic surgeons use tissue expanders and flaps frequently. There is some excitement about fasciotense, an exciting new device. There is a talk on it on 20th. So to conclude, yeah, tissue expansion does seem to be a really good idea, an exciting idea, which can curb a lot of our wound-related problems with surgeries of large hernias. And among the available techniques, Botox seems to be the easiest and most available, followed by PPP. Thank you very much.